Here we are again. Thank you for coming back. This is Your Menopause Your Way, and I'm Menopause Taylor, a gynecologist who is making sure you know how to manage your menopause your way successfully. This is video number 314, and it's part of a unit on cancer in general. I present all videos in a specific stepwise manner so that you have a foundation for understanding everything in subsequent videos. So far, we've talked about the normal cell in video number 309, cell size and cell number in video 310, cell abnormalities in video 311, common characteristics of all cancers in video 312, and the multiple personalities of cancers in video 313. So all this has led us to our topic for today, which is cancer assessment. Cancer assessment includes all the things that transpire in the course of a cancer in the clinical sense. And this video will be critical to your understanding of all the videos that follow it. This is why I like to call this YouTube channel Menopause University. It really is a complete education and the only one of its kind. Now, in my book, both the first edition and the second edition, I give you separate chapters on uterine cancer, breast cancer, and ovarian cancer. And I will be doing the same here in these videos later on. But for now, I'm giving you material that is more of a foundation than what you're going to get in the book. This video and all the videos in this unit will help you assess any kind of cancer. So let's start by delineating all the things that transpire when cancer develops. They include all the following: cause, screening, symptoms, diagnosis, ranking, treatment, prognosis, and survival. And since these steps typically occur in a specific order, I think the best way to address them is to do so in a timeline. I just love timelines. They help you see so much more than just a simple list. So if we were to create a timeline of these factors in cancer assessment, it would look like this. This is just a simple timeline with forward arrows showing the progression of a cancer from cause to screening for the cancer, to symptoms, to diagnosis, to ranking, to treatment, to prognosis, and to survival. And I know it's tiny and it might be difficult for us to see clearly, but let's discuss each of these steps individually and that'll help. They all involve many considerations. Okay, so the first factor in assessing any cancer is the cause of the cancer. Of course, there are different causes of different cancers. But the very key is to know what causes any given kind of cancer. And the big key to cause is risk factors. As you discovered in the units on heart attack, osteoporosis, and Alzheimer's, every disease has a list of risk factors. If you know the risk factors for a cancer, you can exercise your ability to decrease the risk factors over which you have control. The more risk factors you minimize, the lower your risk for that particular cancer. While it isn't impossible for a cancer to be caused by just one thing, most cancers are caused by a number of different things acting in concert to transform a normal cell into a cancer cell. And if you know the risk factors for a cancer and you lower those risks, you are exercising your ability to prevent that cancer. And I always like to link cause and prevention. This is where you have the most power to determine whether or not you ever get a cancer. If you don't know the cause of a cancer, it will not be possible for you to exercise your ability to prevent a cancer. Okay, then the next step in a cancer is the early development of the cancer. This pertains to the time before you have any symptoms that would alert you to its presence. This is when it's still hidden or undetectable clinically. Quite possibly, it isn't even cancer yet. As you learned in video 311, There are many progressive cellular changes that are precursors to cancer. Some screening tests detect them in this pre-cancer stage. Or maybe it's just too small for you or your physician to feel. It's too early for it to disrupt function of the organ it inhabits. So this is where screening tests come in. Screening tests are designed to detect cancers before they even become cancers or before they cause any signs or symptoms of the cancer. A screening test is a procedure that serves the purpose of early detection of a disease. And there are certain qualifications for a test to be considered a screening test. Not just any test will do. A screening test requires all the following. It must serve the public at large rather than the individual patient. It must be inexpensive. It must be simple and accessible. It must be useful when the cancer is asymptomatic or very early. It must focus on the possibility of cancer rather than the actual presence of cancer. So a screening test is a test that you can do on everyone to designate those people with an increased likelihood of actually having the cancer. But be careful. This does not mean that everyone who has a positive screening test will have cancer. So a screening test for cancer will automatically overestimate the number of people who actually have the cancer. In other words, a screening test might indicate a high likelihood of cancer when in fact you don't have cancer at all. In epidemiology, this is called a false positive. It's a test result that is falsely positive. A false positive occurs when the screening test is designed to be very sensitive to the presence of the cancer. In other words, it's better to be oversensitive and indicate the possible presence of a cancer when there really isn't one than it is to be undersensitive and miss a cancer that is actually there. So screening tests have to be sensitive. We call this sensitivity. Sensitivity is the tendency to overestimate the presence of a cancer and have false positive tests in which people who do not have the cancer are designated as possibly having the cancer. This requirement for sensitivity is what makes some people forego screening tests. For them, the trauma of going through additional testing to discover that it was all a false alarm is so traumatic that they skip screening altogether. But it's critical to understand why it has to be that way. I mean, would you rather have a screening test that was not sensitive and gave you the all clear when you really had cancer? The next thing on our timeline is symptoms. Symptoms denote a cancer that is not as early in its progression as one that is discovered on a screening test. Symptoms mean that the cancer has progressed enough to make its presence known. It is significant enough to cause some kind of malfunction in the organ in which it exists. Cancers vary in terms of how early or how late they cause symptoms. So this particular step in the timeline can occupy different positions depending on the particular cancer. Symptoms serve to get your attention so that you know something is awry. Hopefully they occur early enough so that you can treat the cancer, but there are some cancers that produce no early symptoms at all. And unfortunately, there are some that are so advanced by the time they produce symptoms that no treatment suffices. They're already fatal when symptoms develop. The next factor in our timeline is diagnosis. Now, this is when one of two situations occur. Either the screening test detects the presence of cancer before you have any symptoms, or you start having symptoms for which you seek a diagnosis. Generally speaking, the diagnosis will be made earlier by using a screening test than it will by waiting for symptoms to develop. And once you present with symptoms, there are always tests that serve the purpose of confirming the presence of the cancer. These are called diagnostic tests. The purpose of a diagnostic test is to establish the actual presence or absence of the cancer. And just like you saw with screening tests, there are certain qualifications for a test to be considered a diagnostic test. A diagnostic test requires all of the following. It must serve the individual patient rather than the public at large. It must be used for patients with either a positive screening test or symptoms indicative of the cancer. It may be expensive. It may be complex and of limited availability. It must be useful regardless of whether or not the cancer is symptomatic, meaning whether or not it's early or late. And it must focus on accuracy in confirming the presence of the cancer. So unlike the case with a screening test, a diagnostic test will be more specific for the presence of the actual cancer. And we call this specificity. Specificity means that instead of having a tendency to overestimate the presence of the cancer, it makes sure that it does not underestimate the presence of a cancer. In other words, its purpose is to confirm the specific diagnosis. It ensures no falsely negative test results. So specificity is the tendency to confirm the presence of a cancer and have no false negative tests in which people who do have the cancer are designated as not having the cancer. This makes sense when you're trying to pinpoint the cancer and give it a name that defines its personality. So note that a big difference in a screening test and a diagnostic test is that the screening test has to be able to detect the cancer early, whereas a diagnostic test does not. A diagnostic test can consist of a blood test, an imaging study like an X-ray, a CT scan, or an MRI, an aspiration of cells or fluid, or a biopsy. They all provide actual evidence of the cancer, and they constitute the first step in making an actual diagnosis. But there's more to a diagnosis of cancer than just a diagnostic test. So before going on, let's just pause to look at a chart of the differences between screening tests and diagnostic tests. This simply compares the target group, the cost, the availability, the timing, the focus, the sensitivity or specificity, and the false results, either positive or negative, for a screening test versus a diagnostic test. And you can find this chart in the link just below this screen or at menopausetailor.me. Now, the next factor in the progression of a cancer is its ranking. Now, ranking is not a medical term. I'm using it to frame your thinking in terms of designating the severity of the cancer. Think of ranking as something that has two separate purposes. It designates the severity and extent of the cancer, and it dictates treatment options. If a biopsy indicates the presence of cancer, it tells you nothing about the size of the cancer or the personality of the cancer. In the last video, I explained that cancers have personalities. They have characteristics that exist on spectrums for introversion or extroversion, rule following or rule breaking, productivity or impairment, predictability or unpredictability, gentility or aggression, slow or fast growth. But a biopsy result merely tells you that the cancer is present. It also usually tells you what kind of cell became a cancer cell, but it tells you nothing about how large the tumor is or how far the cancer has spread. So even though you have a preliminary diagnosis of the kind of cancer, at this point, you do not have a final diagnosis. The final diagnosis must include much more information than you currently have. Obtaining a final diagnosis may require more tests, or it may require actual surgery in order to finalize the diagnosis. Most commonly, surgery to remove the tumor gives you the most accurate and detailed information about the cancer. So ranking involves two separate designations: grade and stage. Grade refers to the degree of abnormality of the actual cancer cells. In video 311, I taught you many terms that include the root word plasia, and you discovered that they ranged from mild to severe in terms of how abnormal they were compared to a normal cell of the same type. Recall that a well-differentiated cell is very close in appearance to the normal parent cell and can still perform its function. A moderately differentiated cell is halfway between a perfectly normal parent cell and a severely abnormal cell, and it may or may not perform its function. A poorly differentiated cell is so unlike the normal parent cell that it is difficult to recognize or identify the cell type at all, and it no longer performs its functions. Another name for a poorly differentiated cell is anaplastic cell. So ranking is all about designating the cancer's personality based on how differentiated it is. The more well-differentiated it is, the closer it is to a benign cancer. And the more poorly differentiated it is, the closer it is to a malignant cancer. This grading of the cancer may be accomplished with just biopsies of the tumor, or it may require complete removal of the tumor. Sometimes biopsies underestimate the grade of a tumor, and this happens because a biopsy only samples a small piece or a few small pieces of the tumor. There may be other areas of the tumor that contain more poorly differentiated cells. Typically, the grading system for cancers goes like this. GX is the grade cannot be assessed. G1 means that it's well differentiated or low grade. G2 means that it's moderately differentiated or intermediate grade. G3 means that it's poorly differentiated or high grade. And G4 means it's completely undifferentiated and also very high grade. So the higher the grade, the worse the cancer. Now the other parameter of ranking is staging of the cancer. The stage of the cancer designates how far it has spread. And cancers have a progressive way of spreading. I like to divide the steps into 5 processes. These designations enable you to kind of picture what's actually happening at each step to make cancer lethal. The first step is transformation of a normal cell into a cancer cell. You learned about this in video number 311. But mere transformation of a single cell into a cancer cell doesn't amount to much, and it certainly can't kill you. The second step is proliferation of that one cancer cell into many more cancer cells. This is where you have a larger number of cells, but they're all still localized to the organ of origin. And because they're still localized, they don't cause any harm. The third step is invasion. Invasion is when a cluster of cancer cells breaks loose and invades the barrier that's previously kept them self-contained. They break through the wall that kept them in just one place where they didn't cause harm. This is where they begin to invade the surrounding organs and tissues, including lymph nodes. So this is the step where a cancer converts from benign to malignant. Before invasion, it's benign. After invasion, it's malignant. The fourth step is metastasis. Metastasis is when the cancer enters your bloodstream. Once cancer cells are in your bloodstream, they can travel distantly and rapidly. So your bloodstream is what enables cancer to spread to distant organs. And metastasis is the spread of cancer cells from their organ of origin to those distant organs. And finally, the fifth step is dissemination. Dissemination is when the cancer takes up residence in another organ. As your blood circulates cancer cells around your body, the cancer cells decide where they prefer to live. And different cancers choose different organs. They choose organs that will support them the best. And once there, they take up residence and steal the nutrients and energy that the surrounding normal cells need to survive. So the normal cells die and the cancer cells survive. That's what makes cancer deadly. Now, there are two different staging systems for cancer. One breaks the staging down into modes of spread and the other does not. First, I'll describe the one that does not. The first staging system uses Roman numerals 1 through 4 to designate the extent of spread of the cancer. And that staging system is as follows. Stage 0 is carcinoma in situ. Stage 1 is cancer confined to the organ of origin. Stage 2 is cancer that includes the borders of the organ of origin. Stage 3 is cancer that invades neighboring organs beyond the organ of origin, or it involves the lymph nodes. And stage 4 is cancer that has spread well beyond the organ of origin to distant organs. So this staging system addresses the extent of the cancer fairly simplistically. But I do want to clarify and define that first stage, which is stage 0, which is called carcinoma in situ. Carcinoma in situ, or CIS, means that the abnormal cells are very few and exist only as an isolated single group of cells that may or may not ever become malignant. The very fact that this staging system designates it as stage 0 indicates that it is really only questionably cancer. And in most cases, because it is very early, very limited, and not yet a true cancer, all that is necessary to treat CIS is simple excision of the abnormal cells and nothing more. Going on to the other staging system uses a different way of defining the degree of spread. This staging utilizes the 3 means by which cancer can spread. 1, they can spread locally by just outward expansion, just getting larger and larger as they overtake the organ of origin and encroach on the structures nearby. 2, they can spread by invading lymph nodes, first nearby the organ of origin, and then through the lymph system to distant organs. And 3, they can spread by traveling through the bloodstream to distant organs. So 1 means of spread is local, and 2 are distant. And stage takes all these things into account. Because there are these 3 routes of spread, this second cancer staging system uses them to designate how far a cancer is spread. So this cancer staging system is called the TNM system. T is for tumor, N is for nodes or lymph nodes, and M is for metastasis. So the T for tumor designates the size of the tumor. The N for nodes designates the presence of cancer in the lymph nodes. And the M for metastasis designates the presence of cancer cells in other organs. And there are subcategories for the T, N, and M designations that vary based on different cancers, but we don't need to get into all that detail here. So both grading and staging are quite often not known until after a surgical procedure to remove the tumor. And when that's the case, the surgery serves three different purposes. It provides the staging, it dictates whether or not additional treatment is necessary, and if additional treatment is necessary, it determines what kind. For instance, if staging reveals that the cancer was localized to the organ of origin and it was all extracted surgically, there may be no need for additional treatment. But if staging reveals that the cancer has spread beyond the organ of origin, there is usually a need for additional treatment. And the kind of treatment depends on the kind of cell that became a cancer cell. Some cancers are more responsive to radiation therapy. Others are more responsive to chemotherapy. It all boils down to the cancer's personality, and staging helps determine all these things. The words benign and malignant fall into this category of staging too, and they take into account some of the cancer personality traits I taught you about in the last video. A benign cancer is one that is confined to the organ of origin, has well-defined borders between the tumor and the surrounding tissue, is slow growing, and is treatable with surgery alone. A malignant cancer is one that is not confined to the organ of origin, has spread to nearby or distant tissues and organs, is rapidly growing, and requires chemotherapy and/or radiation therapy for treatment. So, if the staging reveals that there are distant metastases in other organs, there may be a need for chemotherapy or radiation therapy to kill the cancer cells in these distant sites. Every cancer is unique. I couldn't help myself, so I made a chart of these steps and staging systems so that you could see how they line up next to one another. Me and my charts. This chart is simple. In the first column, you have the level of development or degree of spread. In the second column, you see the 5 steps that I delineated for the progress of the cancer. In the third column, you see the Roman numeral staging system. And in the fourth column, you see the tumor node metastasis staging system. And that brings us to the next factor in the progression of cancer, treatment. The goal of treatment is to kill cancer cells without killing normal cells. The specific treatment for any cancer depends on the organ of origin of the cancer, the grade of the cancer, the stage of the cancer, the differentiation of the cancer, the personality of the cancer, the health of the patient, and the patient's preferences. Cancer treatments fall into 3 broad categories: surgery, radiation therapy, and chemotherapy. Some cancer treatments are more brutal than others, but the treatment must be tailored to the individual cancer. Please do not compare cancer treatments because every cancer is unique. Even if someone else has the same cancer diagnosis you have, they do not have your cancer. Comparing cancers and their treatments is a setup for a lot of confusion. And the next factor in the progression of cancer is prognosis. Prognosis refers to the forecast of the cancer or the likely course of the cancer. It's a prediction based on everything we've discussed thus far. Of course, a prognosis is not an absolute or concrete thing. 2 people with the very same cancer can have very different prognoses. This is because there are just so many factors that contribute to prognosis. When a doctor gives you a prognosis, it is not your destiny. No prognosis takes into account all the things outside the actual assessment of the cancer itself. But since no 2 patients are alike and no 2 cancers are alike, a prognosis is merely a guess. Most of the time, doctors use statistics to give you a prognosis. This means they compare your cancer to the average outcome for other people with the same cancer. And while that's about as objective as they can get, it certainly doesn't take into account all the things that can influence the prognosis. Prognosis almost never includes the things over which you have control, like your diet and lifestyle. So never let a prognosis blind you to the fact that it is only a guess. And finally, we have survival. Now, when it comes to cancer, the word survival has a limited meaning. Because cancers tend to be deadly, the survival rates for cancers typically focus on short-term survival. It is common for cancer statistics to cite 1 year, 5-year, and 10-year survival rates. And these survival rates do not designate whether they include disease-free survival or not. Survival rates also tend to ignore quality of life considerations. Of course, most people who have had cancer are most concerned with mere survival, but I actually think it would be more helpful to depict quality of life, survival with cancer, and survival without cancer. Some people live with their cancer and have a good quality of life. Others cure the cancer but go on to have a very poor quality of life because of the treatments undertaken in order to cure the cancer. And a lot of this has to do with value systems. I mean, some people would prefer a shorter, higher quality life over a longer, lower quality life. It's a very individual matter. So there you have it, the steps in the progression of cancer assessment. And we will be using this information in future videos. You know how I am. I build one thing on another. So here's the whole series of steps as a timeline. Now I know this is too tiny for our old eyes to decipher, but it's just 8 blue circles bearing the 8 factors in the progression of cancer, which are cause, screening, symptoms, diagnosis, ranking, treatment, prognosis, and survival. And in the arrow to the right of each blue circle, I've designated the subtopics that I presented for each factor. For cause, I've designated risk factors and prevention. For screening, I've designated sensitivity. For symptoms, there are no subtopics. For diagnosis, I've designated specificity. For ranking, I've designated grade, stage, and benign versus malignant. For treatment, I've designated surgery, radiation therapy, and chemotherapy. And then there's prognosis with no subtopics, and finally survival with 1-year, 5-year, and 10-year survival rates. So this is where we will end today. Next week we will discuss the emotional aspects of cancer. Until then, be sure to visit my website, which is menopausetailor.me, schedule a consultation, read some articles, shop in my online store. You can find the chart of differences between screening tests and diagnostic tests, as well as the chart on steps and staging on my website or in the link below this screen. If you still have some free time, you can follow me on Facebook, Twitter, and Instagram. And you definitely have time to subscribe because it's something you can do right now with a single click. Okay, bye!